Hi, and thank you for joining our webinar today with Lisa Hileman and Sandi Holahan, two of our VCU Health lactation consultants and PD nurse practitioners. Today, Lisa and Sandi will discuss issues that can be hard for our new moms. We're talking about breastfeeding. Breastfeeding has many benefits for both mom and baby, but we know that it's not always easy. But don't worry, Lisa and Sandi are going to share some tips and best practices of how VCU empowers you to have the breastfeeding experience you want. With August being Breastfeeding Awareness Month, it's the perfect time to have this discussion. My name is Debbie Schumacher, and I'm a member of VCU Health's marketing team. Before we begin the presentation, I'd like to make note that we will hold questions till the end. But if you have any, please put them in the comment section and we'll address them at the end of the presentation. Now let me tell you a little bit about Lisa and Sandi. Lisa Hileman began her 24-year nursing career on the mother-infant unit at VCU Health after earning her bachelor degree at VCU. She also has a master's degree in nursing education from the University of Nevada and a postmaster's degree from UVA as a family nurse practitioner. Lisa provides inpatient and outpatient breastfeeding support to our new parents. She's the mother of 3 young men and a grandmother to 4 grandchildren. Let me tell you a little bit about Sandi. Sandi Holahan is a pediatric nurse practitioner and lactation consultant who has been with VCU Health for 10 years. A West Coast native, she earned her bachelor's degree in nursing at the Pacific Lutheran University in Tacoma, Washington, and continued her studies at the University of Pennsylvania. She's been practicing for 30 years. She enjoys her current role as a newborn specialist and lactation consultant, working with families during this precious time in their lives. Sandi is the mother of 4 grown children and has been happily married for 32 years. Thank you, Lisa. Thank you, Sandi, for joining us today. That's a lot of degrees and longevity between both of you. We are so lucky to have your talent here at VCU Health. I'm now going to turn the show over to you.
Great. So my name is Lisa Hileman. I am a family nurse practitioner and a lactation consultant, and I'm happy to be here with you. So I want to start with telling you the benefits of breast milk. Breast milk provides the best outcomes for mothers and babies. And if you are choosing VCU Health to have your baby, you are in the best place because we are there to support you. Education and support starts at prenatal care and goes right through the first year of the baby's life. In the hospital, I can assure you, you will be seen by a board-certified lactation consultant 7 days a week and as many times as you need to be seen. And then after discharge, we have continued care at 2 locations of our lactation clinic, both in downtown Richmond and Shore Pump. Next slide, please. Why is breast milk best for your baby? Well, the American Academy of Pediatrics recommends that babies receive only breast milk, no formula, no water, no juice, no infant cereal for the first 6 months. And breastfeeding should continue through the first year and beyond if it works out for the mother and baby. Many people breastfeed throughout past the first year. You can continue breastfeeding even after starting solid foods with your baby. Next slide, please. There are so many benefits of breast milk for baby. I've only listed a few here, but it has been shown through evidence-based information that breast milk decreases ear infections, eczema, and asthma. There is a decreased risk of diabetes and leukemia. The antibodies from the mom provide extra immunities to these little babies who don't have great immune systems when they're first born. And every mom's milk is perfectly specifically produced for her own baby. So your baby will get specially produced milk, directly produced just for your baby. And of course, and very importantly, breast milk reduces the risk of sudden infant death syndrome. Next slide, please. So how to be successful? You want to feed your baby according to the cues. So we don't really watch the clock when we come to breastfeeding. The baby becomes the clock. You want to make sure the baby's mouth is open wide, sticking out his tongue, making sucking noises, putting his little hands to his mouth, turning his head towards the breast. Those are what we call feeding cues or feeding signals. Crying is actually a very late sign of hunger, and it can be more difficult to get your baby latched if he or she is crying. You want to keep your baby skin to skin as much as possible. This will help your baby to breastfeed better. And at VCU Health System, all healthy babies are placed directly on the mother's naked chest as soon as the baby is born to initiate that first skin-to-skin activity. The baby will smell you, you'll smell your baby, and the hormones of breastfeeding will start flowing. You want to stay with your baby the entire stay, so your baby and the mother will not be separated. You will stay together from the time the baby is born till the time you are discharged. This lets you respond to your baby's hunger cues and learn them. It develops trust between you and the baby. Next slide, please. It's important, especially in the early days, to feed a minimum of 8 to 12 times in 24 hours, again, according to the baby's cues. So, like I said, it's not going to be every 2 hours or every 3 hours. It might be at times every hour because your baby might be giving you those cute little feeding cues. You want to let your baby breastfeed for as long as he or she wants. Try to avoid pacifiers until breastfeeding is well established. That often takes up to 2 weeks. Offer both breasts at every feeding. You always want to alternate your starting breast. The baby is always going to be more vigorous on the first breast, so you want to kind of share the wealth and not always start on the same breast. And very importantly, massage your breast and manually express droplets of colostrum, which is the early milk, prior to latching your baby. It will entice your baby to open wide and will increase your breastfeeding milk supply. Next slide, please. Deep latch is the key to successful breastfeeding. You want the baby to open her mouth wide, take a big mouthful of breast, and you want to hear your baby sucking and swallowing. But don't worry, this does not come naturally to everyone. We will help you master this skill. You need to have patience and perseverance. It will get easier with time. And there are several positions for breastfeeding. We will show you all of them and see which one works best for you. If your baby has a shallow latch, which means the baby does not have enough breast in her mouth to transfer milk, this can lead to nipple soreness. Next slide, please. So let's talk a little bit about VCU Health System and the Elite Baby Friendly designation that we earned back in 2015. We were the first hospital and continue to be the only hospital in Central Virginia to have this honor. Baby Friendly exists to educate, empower, and train new moms, and we are always on top of the best practices. Most importantly, we will support you through your whole journey from beginning to end. You will feel well supported, and you will need that support. And we cherish this honor to be able to spend this time with you and your new baby. Next slide, please. So now I'm going to hand it over to my very lovely colleague, Sandi Holahan. We've been working together for a very long time, and I'm so honored to be doing this presentation with her. And here's Sandi.
Thank you, Lisa, and thank you, Debbie, for the nice introduction. On the heels of the baby-friendly designation, I have to say that as a newborn specialist and a mother of 4 who breastfed all 4 children, I had never seen a lactation consultant, and I wasn't really sure if that was a part of what I wanted to do. But when the more I worked with new mothers in the hospital, the more I realized I was not very good at helping mothers breastfeed. So it was that decision then to go ahead and become trained to be an outpatient lactation consultant. And it has really been a very, very rewarding part of my practice. And I'm so glad I did it. As we were designated baby friendly, we also were able to expand our outpatient lactation services. And I think it's critical that mothers have somewhere to go after they're discharged from the hospital. You can't really learn anything in 1 or 2 or even 3 days. You can learn some basics of breastfeeding, but it usually changes once you get home. And that's why outpatient services are so important. We see patients in mothers and their babies, along with the father if they want to come, or another support person. That's perfectly fine. We take an hour with the patient and the mother in the room in the clinic at Shore or over at Short Pump, Ridgefield and Pump Road. We have a clinic 5 days a week, and each visit is 1 hour long, so that we can really get into the nuts and bolts of what the goals are and what we want to do to support a mother who wants to breastfeed. The number there is listed for our clinic, and our staff is made up of 6 nurse practitioners. We're all lactation certified, and we have 1 physician who's been doing this for a long time here in town, and she's delighted too that we have more help now. We also have a program coordinator. Her name is Lisa. She takes all the phone calls, and even if somebody is calling to find out about how to make an appointment or to get into an appointment, she can triage over the phone and maybe be of some help before you even come in to visit. Next slide, please. The types of things that we see in the clinic. Now, again, this is after mom has gone home, the baby is fussy, maybe isn't latching anymore. Mom is usually very anxious. Mom is the only one with the breasts, and sometimes it's hard and it's frustrating to feel like she's not being successful with getting the baby to feed very well. Like Lisa mentioned, the latch is one of the most important, is really key to having a good, successful breastfeeding. And so it's very, very important to get that right. And I try to usually tell parents that there are 3 goals from my end of from seeing the patients. And it's number 1 is eventually we want to see the baby gain weight well with time. Number 2 is that we want to maximize mother's milk supply. And number 3 is that we want a good latch. And if we can accomplish those things together, we're going to be successful. The latch on the breast should not cause toe curling pain. And some women really struggle with this. It's definitely something that is not comfortable necessarily, because women who are first-time mothers have never had this experience before. So naturally, it's going to be perhaps uncomfortable, but it should not cause toe curling pain to where mothers dread putting the baby on the breast. If that's the case, then there's something wrong, and that's why we're there to help you. And I'll talk a little bit more about that later. Low milk supply often is the case at the beginning when mothers breastfeed. The initial attempts at breastfeeding, there's very, very little milk. It's called colostrum. It's very, very rich in nutrients and really good for baby to have, but we don't deliver a baby and automatically have this huge amount of milk for baby to feed. So that needs to be, parents, mothers need to understand that. And what we want to do is then address any risk of not having a full milk supply, and we can talk about that. Usually mothers are able to make enough milk for their baby. Engorgement happens when the breasts fill up, which is basically the transition from the colostrum to full milk. That often happens between 3 and 5 days after delivery. Women really struggle with that, or engorgement throughout the breastfeeding experience leading to mastitis, and we can deal with those types of things in the clinic. Breast refusal refers to babies who just don't want to get on the breast for whatever reason, and we'll help figure out what happened there. Tongue tie or tight frenulums is kind of a hot topic in lactation, and we can look at babies who have a tight tongue and decide whether or not that tongue needs to be clipped. It's called a frenotomy, and we do that procedure in the office in the lactation clinic. But again, it's a gray area, and we try to avoid doing it immediately and see how things are going, and if that's possibly the cause for slow weight gain or low milk supply for mom. Preterm babies have their own set of challenges with breastfeeding, mostly because their oral motor strength is very weak. And sometimes they have a little bit of a harder time pulling the milk out of the breast. Some of these babies need supplementation, and yet I've seen 36-week babies who do really, really well at the breast and don't need anything. But it's a good idea to take a look and see if things aren't going so well. We have moms bring their pumps into the clinic for help with pumps. As everybody knows, pumps are provided. Usually the obstetrician during the last part of the pregnancy will offer a prescription for a pump. And these are paid by every insurance company. But they land on your door and you don't know really what you're supposed to do with this pump if you're a first-time mom. So if you make an appointment, you should certainly bring your pump with you, and you'll be instructed to do that with all of the parts and the power cord and everything else. Pumps vary in their usage, and we have some experts for pumps. Breastfeeding multiples refers to if you have twins or triplets. How's that going to work? And we can help with that. Emotional support I put there because this is not an easy time. Mothers are stressed. There's a high incidence of having maternal depression after having a baby. And sometimes the breastfeeding experiences, a negative breastfeeding experience can add to that. As well, we're also really good at being able to see how things are going and being able to just say, well done, and never see them again. Sometimes the first-time mother needs some reassurance that things are going well, and that's what we can provide, and we're happy to do that. And it's really, really rewarding. I see some patients one time and never see them again. Sometimes I'll see a patient twice a week until they kind of graduate out of clinic or even choose another path. So that's what we do mostly. And those are the most common reasons that we see patients in the clinic. Next slide, please. The first thing I like to do when we have a mom come in with a baby is talk about what her goals are. Is her goal to exclusively breastfeed for the first 6 months, or maybe for the year, or until she goes back to work? But establish those goals and let's decide together how we can achieve those goals. Then we discuss the birth history, whether baby was delivered by a vaginal delivery or a C-section. That can impact how quickly the transition of milk occurs, and that's important for us to know. Babies that I hope I mentioned before that babies do not need to be born at VCU in order to be seen in the clinic. We see patients from all over. Some drive a long way to come into the lactation clinic. So any baby and mom is welcome to be seen at the chore or the Pump Road office. We'll review the baby's delivery, whether the mode of delivery, as well as any issues that might have happened at the delivery or during their time in the newborn nursery, how quickly they went home, what kind of support they had. We'll review the risk factors for a mom. Has she had breast surgery? Has she had reduction surgery or implants? And what kind of medication is she taking? And we'll take a look at mother's anatomy. We also examine the baby, take a listen to the baby and see if development is good or normal. Does the baby have a tongue tie like I mentioned before? Is there anything anatomically in the baby's mouth that might prevent a good latch? And what else can we do to try to make that the best latch possible? We are able, because we have an hour of time with you, what we'll do is put the baby on the breast in a good position with the baby always up to the breast, not the breast to the baby, and work on a good latch. And then we can measure the weight from before the feeding to after the feeding. And that's called a weighted feed. And that tells us how much the baby was able to transfer from the breast. Initially, some babies will only take 10 to 20 milliliters of milk, and that's okay. As the baby grows and as mother's milk supply becomes more robust, then those babies will usually transfer more. But that's an important part of our assessment when we see you in the clinic. When we are by the end of the hour, we have a plan that we print out for you to make sure that we're meeting those goals of breastfeeding, and then whatever follow-up needs to be done. And like I said, sometimes we don't see somebody for again, and sometimes we'll see it in a few days just to make sure the weight is increasing. Remember, babies can take up to 2 weeks to get back to their birth weight, and this is normal. Babies lose weight, they poop and they pee more than they get in initially, and so their weight is going to drop. And a lot of mothers worry that they don't have enough milk, and that needs some reassurance that we'll try to get them back up to their birth weight by 2 weeks of age. We work with pediatricians locally, and if we see a patient that is not followed by our pediatric practitioners, then we'll send a note to the pediatrician that referred the baby and the mother to us, and sometimes even make a phone call to see how things are going and to see what kind of follow-up they're going to have. Next slide, please. This is really the last slide. I just wanted to add some breastfeeding tools that you can see out on the market. There are lots of products out there. There's all kinds of things, and I'll explain them. The first one under the tools word is a shell. Sometimes those are given out by lactation consultants in the hospital to kind of protect the nipple. This one here catches letdown, the milk that is being expressed or being released during a letdown phase when the mother is breastfeeding on one side, and that letdown, or just walking around the mall and hearing a baby cry, can cause a letdown, and those shells can catch some of the milk. The other one here with the baby on the breast, that's called a supplemental nursing system, and we recommend it for babies who aren't getting enough volume from the breast from the mother, but it's a tricky thing to work and should only be used with the guidance of a lactation specialist. But I just wanted you to see that there are lots of tools out there. Nipple shields are given out often in hospitals, and as you can see, there is an easy pointed plastic piece of that makes it easier for the baby to latch onto the breast. I'm not a big fan of nipple shields, although sometimes they are needed to get the baby to the breast, and it is a tool in our tool belt, and we can use it for a while, but while we're using it, we need to have close monitoring of how mom is doing with using it, how well the baby is transferring milk, and with the goal of not using the shield eventually. The manual pump there is, like I said, a manual pump. That is not an electric pump. There are too many electric pumps to even start putting them on a slide. They all have their pros and cons. You can consult friends who've used pumps if you're considering buying a pump, and they all should have around the same vacuum. Some are easier to use, some have a night light, some have different cycles that are automatic, some that you have to program. It's very confusing. So the best way to learn about this is, depending on which pump you get, is to try to look at their YouTube video, or bring it into a clinic where there's a lactation consultant that can help you with it. The other picture there is of some gel pads, and gel pads are just a product that are put out to protect the nipple. They are very soothing. They're not absorbent, but they're kind of a nice thing to have. So there, like I said, there's lots of products out there. Be very careful. There's so much information about breastfeeding, and we're here to help you be successful if that is your goal. And I think I can leave it up to questions now, and back to Debbie.
Wow, that was so informative and insightful, both to Lisa and Sandy. Thank you. I wish you both were around when I was breastfeeding. I'm really used to. I'm like listening, going, "Oh, did not do that." I was watching the clock, the literal clock versus my baby's clock. The things you learn. So VCU Health and our patients and the community is just so lucky to have this experience and dedicated information and lactation consultants like yourselves. It just makes the breastfeeding journey so much more of a positive experience. So just thank you. And as they mentioned, their support doesn't stop. You can tell it really radiates through. So, and the support doesn't stop. They got recently, our team got recognized by the International Lactation Consultant Care Award as recognition of the breastfeeding support and training, both in the hospital, outside the hospital, within the community. So congratulations. We're now going to open the floor to questions. There were some questions that came in ahead of time, so I'm going to address those first. This one's a very timely one with COVID-19 and the vaccine. Should I get the COVID-19 vaccine while breastfeeding? Sandy, why don't you take that one?
That's a simple yes. You should get the vaccine to protect yourself. During breastfeeding, the immunity is transferred through the breast milk to the baby. So it's beneficial for mom and baby. So the answer is yes. And that has been a recent publicized statement from ACOG, which is the obstetric guiding rules, if you will.
I also know that they say do not stop breastfeeding if you want the vaccine. So don't just, if you're going to get the vaccine after you deliver, still continue to breastfeed. Is that correct?
Yes,
is that what you think too?
Yeah.
Okay. Here's one for you, Lisa. Is there a correct way to hold my baby when breastfeeding? I used all these pillows and options.
So yes, so there are a lot of items on the market, the Boppy, the My Breast Friend. You could just use regular pillows, but you will need to support your arms because you will be doing this about 12 times in 24 hours. The positions we usually go to are the football hold, the cross cradle hold, the side lying position, or the regular cradle hold. And you will be shown all these positions. You will be able to pick one or two that are the most comfortable for you. It's very important that you're always supporting the back of the baby's shoulders and back when you're feeding and supporting your breast as well. This is something that comes with practice, and we are here to help you with that.
Great. And then, Sandy, you did talk a little bit about this, but maybe you can elaborate. Is it normal to only have a small amount of that first milk, the colostrum, when you start to breastfeed? And what does it look like? And, you know, how do you know, how long does it take for the milk to come in?
Yeah, so it's very normal to have that first milk or colostrum. And sometimes it looks like so little that you can't even believe your baby would be satisfied with it. But the baby's stomach is extremely small, about the size of a large marble. And that's all the baby needs is those first few drops. It's really important to empty that out of the breast so that the milk can transition and fill up with full milk. And that can take 3 days, 5 days. And that transition is easy to tell because your breasts will become very full and you'll know it for the most part. And after that, then that milk is full milk, considered full milk, and is much easier for the baby to fill up on as that baby's little tummy grows.
Okay. And then Lisa, here's one about discomfort. What should I do if I experience discomfort or sore nipples when breastfeeding? I know there were some of the tools that Sandy shared, but is there other things that you'd recommend, like putting any salves on it or?
So it always goes back to the latch. That's the first thing we want to look at, because if the latch is not right, then that's where the sore nipples usually begin. But if one experiences sore nipples, the first thing you want to use is your own colostrum. It's very healing, it's full of antibodies, and it's great for your nipples. So what we have new moms do when they're having that initial nipple discomfort is hand express a little bit of the colostrum, put it on their nipples, let it dry to a crust, and do that every time that they nurse. That's the most natural, best way to do it. We also use the gel pads that Sandy had in her part of her presentation. Sometimes we use Epsom salt soaks, which are also a very easy and natural solution. And there are many commercial salves available on the internet. Always ask your lactation consultant or your doctor before placing any other things on your breast. You want to use the most organic, natural, least amount of additives in anything that you put on your breast. And it's also important to know if it's something that you need to wipe off before the baby goes to the breast. Mostly we recommend products that you do not have to, that are perfectly safe for the baby.
Thank you. Here's one from the audience. Are you able to exclusively pump to feed, or is it important to breastfeed and pump simultaneously? That's a good question.
I'll go ahead with that. So people who want to exclusively pump to feed are signing up to do a lot of work because they have to pump and then they have to feed their baby. And it's really a personal preference as long as mom is well educated about what she's getting into. A lot of mothers are anxious about how much volume of food is going into their baby. That's so understandable because the mother is the only one with the milk. We live in a society where we want to measure. People who give formula have ounces that they can measure and know exactly how much the baby is getting. So I see a lot of mothers want to exclusively pump to find the volumes for which they would then feed their baby. So I guess it is a very complicated question because it's full of different situations. Exclusive pumping can be kind of a drag. And yet if a mother doesn't want the baby on the breast, then that's still better than giving formula. So that's okay. But putting the baby to the breast and feeding exclusively at the breast is still recommended. It's better for the baby and better for mom. I'm not sure, Lisa, you may have some things to add. I think we all have different experience with pumps.
I think it depends on what the ultimate goal is of the mother. Now, there are some NICU babies who will never make it to the breast because they started out so small. So exclusively pumping in some cases may be the only choice. Exclusively pumping is dedication around the clock, just as feeding your baby is anyway. But you will still have to pump as many times as you would be putting your baby to the breast. So the expectation to sustain your supply when you're pumping is still at least a minimum of 8 times in 24 hours. That means still setting your alarm at night and getting up and pumping your breast. And then as Sandi said, when you're done pumping, it's not just, okay, put the pump away. It's then you have to feed the baby the milk that you pumped. One of the things that people like about pumping, though, is instead of saying, okay, I'm the one who has to feed my baby, I could hand the bottle over to my partner or significant other or whoever's helping me and say, okay, I'm done with my part pumping, you feed the baby. So there is that benefit. And of course, mothers often have to go back to work, and pumping does become a necessity to sustain your milk supply when you are at work. So I feel that most people wind up doing a combination of pumping and breastfeeding. In a perfect world, it would be great to exclusively breastfeed for at least the first 4 to 6 weeks, if possible. And not have to add that extra accessory of pumping. Mm-hmm.
Well, here's a good question that follows up on the pumping. How long can I store the breast milk after pumping? And I don't know if you, Sandi, if you want to take that or
no,
Lisa.
That's we print out information, but breast milk is good at room temperature for an hour. It's good in the refrigerator for 4 to 5 days and in a freezer for 6 months. That's a general gist of it.
And here's another question.
The CDC has.
Sorry, Lisa, go ahead.
I was just going to say, that's okay. I was going to say the CDC has some good guidelines that are easily available on the internet. And I often print them out and give them to my patients to hang on their refrigerator and refer to them because there's so many different times to keep up with.
Okay. And here's one about multiples. Do you have any advice for breastfeeding twins? Either of you. Lisa, you want to start with that? Because that would start in the hospital, I would imagine, helping our moms.
Yeah. Yeah, so in the beginning, I often tell my twin moms, start with one baby at a time. Breastfeeding both babies at one time is a talent that one must work up to. So practice with one baby and then practice with the other baby. And within a few weeks and with some good guidance from your lactation consultant, you will be able to simultaneously feed your babies at one time. The amazing thing is your body knows that you had twins, and your body will make enough milk for both babies. If you have triplets, your body knows that you had triplets and will make enough milk for the 3 babies. So unfortunately, we don't have 3 breasts, so that takes even a little more practice.
And then here's a good one. What recommendations do you have for someone who's really tried and for whatever reason, they just can't breastfeed? What do we do?
I guess the question is, why can't they breastfeed? Is it because the baby won't latch at the breast? Is it because mother doesn't have enough milk and has risk factors for not having an adequate milk supply? Is it because the pinching and the pain is so severe that she doesn't? So it's hard to know without knowing the exact patient that is. If she can't breastfeed, then she can either get donor milk for a while in the hospital. She can purchase donor milk, which is rather expensive, or she can just have the reassurance that if she can't breastfeed, formula is okay. And sometimes mothers need to just hear that it's not, formula is not poison. Sometimes things don't work out and it's okay. Love their baby, keep the baby safe, and feed the baby.
Okay, that makes
I
a
just
lot
want
of
to point
sense.
out that we support mothers. I just wanted to point out that we support mothers in whatever feeding path they take. Not everyone has the same path.
Yeah. And even some others who thought that they were going to exclusively breastfeed, it didn't work out for whatever reason there is. And so we're perfectly comfortable supporting a mother to say, you know what, you've done great. Whatever breast milk your baby gets is beneficial, and the rest is formula, and that's okay. We don't want to cause mothers more anxiety and stress. And again, it's supporting the mother and giving her the right information and not making her trying to alleviate some of the guilt that comes with motherhood anyway. So
that's great advice and very reassuring. And I think this will be our last question. Any advice for tandem feeding a baby and a toddler? Lisa, you want to try that?
I can start that one. So your body knows that you're pregnant and your body knows that you're having a brand new baby. So your body will revert what is a mature milk supply that you've been feeding the older baby back to colostrum so that your baby can get that first milk again. So there are times during this period that the toddler looks at the mom and is like, what is this? Because it doesn't, I'm assuming it doesn't taste the same, it doesn't look the same, it doesn't feel the same. So there will be that transition period where the milk goes back to colostrum, and then it will, of course, come back to the full milk that the toddler is used to. The best advice would be please feed the newborn first, because the newborn is getting 100% of nutrition from your body. The toddler likely is eating complementary foods. So feed the baby first. The toddler will probably want to be right on top, right there with you, but in the best way you can explain to your toddler, however old he or she is, that the baby has to go first in this situation.
Do you have anything else to add on that one,
No,
Sandy?
I was waiting for Lisa to mention to feed the newborn first. So that's the most important thing.
Sounds key. Well, thank you, Lisa and Sandy. What a pleasure it was having you join this discussion. I hope our new moms have learned about many of the
Very
ways
enjoyable.
VCU Health and many of the
Very
ways
enjoyable.
VCU Health and award-winning team empowers us, our new moms, to have the breastfeeding experience they want. We hope you know that you aren't alone and there is help available when you need it. So here's that number again to call to reach our lactation consultants. It's 804-828-2467. They're in the office 5 days a week, but they're also available to do virtual visits also. For more information about breastfeeding, you can visit vcumom.com and follow VCU Health on Facebook. Thank you, Lisa. Thank you, Sandy. And thanks
You're
to all who
welcome.
joined us. Have a great night.
Bye.
Bye.
Thank you. You guys too. Bye.
Bye-bye.